Hello, I'm Dr. Tony Magliocco. Welcome to another episode of the Cancer Informant. Today, our topic will be cancers of unknown primary. It's surprising, but in a subset of patients, there can be a condition where it is known that the patient has developed a cancer, but we don't know where the cancer has started or what type of cells make up the cancer. This creates a significant problem because if we don't really know where the cancer has begun or what its composition is, we're really stuck on how best to treat that particular type of cancer. Now, cancers of unknown primary were as common as 25% back in the 80s, but today it's fallen down to probably around 10% of cases. This is because of our improvements in imaging and diagnostic modalities. If you do happen to have a cancer of unknown primary, there's several things that can be done to help resolve the matter. First thing is it actually diagnosed correctly? Because to really give a diagnosis of cancer of unknown primary, it's important that a patient has had a proper workup. This means that we really need to have a detailed medical history. Did this patient have any sort of cancer in the past? Because it's more likely that a cancer will reoccur than a new cancer might develop. It's also important to know if the patient has any strong family history of cancer, because we might know if the patient comes from a breast or colon cancer family that their tumor may have arisen in one of those sites where their other family members have seen tumors arise in the past. In addition, occupational history is also important in terms of, did the patient have any exposures that might predispose them to cancer? For example, working in an asbestos mine, or being exposed to certain herbicides that are now associated with cancer risk. There could also be previous cancers that have had treatment. Perhaps years ago, the patient may have had a Hodgkin's disease or some other type of cancer that might have been treated with radiotherapy or chemotherapy. In these instances, a secondary cancer can sometimes arise as a consequence of toxicity from the primary cancer treatment. A good workup of the patient includes this medical history, but also a close examination of radiological findings. Are there lesions in the chest? Is there something in the breast or in other parts of the body that can point to a position of origin? Also, additional testing can be quite useful in terms of blood tests. For example, even a simple CBC can show if there's anemia. Anemia might point towards a GI hemorrhage or other source of bleeding that can be hidden from the patient or from their doctors. A close examination of the urine can also point towards underlying malignancy. For example, a bladder cancer or kidney cancer might have malignant cells in the urine. Obviously, for a woman, a close examination of the cervix and of the ovaries are necessary. Chest x-rays are very helpful in terms of looking at the condition of the chest, and CT scans of the abdomen and pelvis can be extremely helpful. A woman should have breast examination and mammography. In a man, close examination of PSA and prostate exam is also warranted. These tests can often help pinpoint the source of the primary tumor. The next step that is very important is actually getting a very careful and detailed pathology review. A pathologist can be extremely helpful in pinpointing the origin of a primary tumor. A pathologist has a number of tools available. First of all, they can look at the tumor on a regular slide, something called an H&E, and from the appearance of the tumor, we can determine what sort of tissue it might have originated from. For example, the tumor cells may be forming glands, which will tell us it's originated in a lining or a glandular epithelium. The tumor cells may have a pigment, so perhaps they're brown. This might tell us this is a melanoma. Or the tumor cells may be making things like bone or cartilage, again, pointing us towards an origin as a bone-forming tumor or as a type of smooth muscle type of tumor. The pathologist also has other tools called immunohistochemistry. These are special stains that we can utilize to stain for proteins. So certain types of tissue have very specific proteins that are associated with their tissue of origin. For example, breast cancers often express estrogen receptor, progesterone receptor, and other markers, mammoglobin or GATA-A, etc. So these immunohistochemical markers can be very helpful in pinpointing the origin of the tumor. In addition, there may be a blood test that includes markers like CA19 or CEA or some other marker, PSA, that can be extremely helpful in highlighting that there could be an underlying GI malignancy, pancreatic malignancy, or prostate cancer. Again, going back to the tissue, there are certain markers that are associated with lung cancer, sarcoma, malignant melanoma, hematologic malignancy, malignancies that pathologists are well familiar with. Now, as molecular diagnostics has progressed, there's another set of tools called methylation profiling. Methylation profiling is a very powerful set of analysis that looks at the DNA of a cancer. So if we look at a normal cell and, for example, compare a liver cell to a brain cell, the differences in the genes are very minimal. In fact, they're probably identical. Every cell in your body has about 5 billion base pairs that are mostly identical in each and all of your cells. So what distinguishes a brain cell from a toe cell? Well, it's really which of those genes are switched on and off. And those are switched on and off with a process called epigenetic modification or methylation switching. We now have tools that can measure all of the epigenetic switching in a tumor. When we measure the epigenetic switching pattern in a tumor, we can actually run it through a machine learning or a cluster algorithm to tell us what sort of tumor this is. So using these machine learning algorithms or principal component analysis in mathematics, we can now take an unknown tumor and accurately identify what is the tissue of origin. Why is this important? Well, it might be important to get accurate staging, because if the tumor is from the lung and it's confined to the lung, this would make it a stage 1 or 2 tumor. However, if the tumor is from the lung and you find it in the brain, this would make it a stage 4 tumor. Staging is important to accurately measure the prognosis and probability of survival. Also, knowing where the origin of the tumor is from can help with treatment, and particularly sometimes with payment of treatment as well, because certain therapeutics are only approved for certain tumor sites. Some of the newer generation drugs might only be approved for use in a lung cancer or a pancreatic cancer or a melanoma. And if we aren't certain where the tumor is from, those drugs may not necessarily be available for use. And if they are used, the insurance company might not pay for them, creating a problem for classification. Further, it can be very important to know the origin of the tumor to gain enrollment onto a clinical trial. It's important if patients can get access to a clinical trial. This can give them the ability to utilize novel treatments, novel innovative treatments, and also potentially a free cost of therapy and treatment management. Being able to qualify for a treatment is extremely helpful and useful. Now, one of the other things that can be done is that if the tissue is not available, because sometimes a patient may have a tumor that's taken and the tissue sample is actually quite small, there may not be any tissue left for further analysis for the pathologist. Pathologists can go back and sort of look at what's been done already in terms of to try to make an opinion about what's going on in the tumor, or else pathologists might consider a liquid biopsy. A liquid biopsy is essentially a blood test, and from the blood test we can measure if there are circulating tumor cells or if there's fragments of DNA. Also, there may be circulating methylated fragments of DNA, which when analyzed with the proper methods can determine the tissue origin of a cancer. So there are many tools available. There are also some exciting new developments in the area of artificial intelligence. We are now training machine learning algorithms to look at simple slide images, for example, H&E analysis, to be able to predict what is the origin of the tumor. They can also identify if there's potentially underlying mutations that are linked to particular therapies and predict the outcomes from these types of cancers. It's also important that if you do have a tumor of unknown primary, that it is properly and fully molecularly worked up, because as we're going forward, it's now clear that more and more of the new therapeutics may not be necessarily specific to one tissue type, and they're gaining broader approvals from the FDA to be utilized in pan-tumor indications. So in these situations, it doesn't really matter what the origin of the tumor is. If it has a KRAS particular mutation, it may be eligible for one of the new anti-KRAS therapies. Likewise, if the tumor has a high tumor mutational burden or microsatellite instability, those particular cancers may be eligible for immunotherapeutic treatments as approved by the FDA and in general covered by insurance. In summary, if you do have a diagnosis of a tumor of unknown origin, it is important to go the extra mile to try to determine what in fact is the tissue of origin. There are many tools that can help solve this problem. This involves a proper clinical examination, proper history taken, looking at x-rays, looking at markers in the blood, and then getting a really good pathologist who has tests available that can really narrow it down. Once we have the tumor narrowed down, this can open up new specific treatment opportunities and can help a patient qualify for clinical trials. But also remember that there are certain pan-tumor indications, so certain molecular features can qualify a patient for therapy even if we don't exactly know where the tumor has come from. This can be very helpful for a patient with a later stage disease. Finally, liquid biopsy is extremely helpful if we don't have any tissue left, to determine what sort of cancer is present in the patient and whether it's progressing. I hope you enjoyed today's discussion of tumors of unknown primary. Please visit our website and YouTube channel to review recent other episodes about other cancer topics. We enjoy interacting with you, and if you do have questions for the Cancer Informant, please post them on the website. The Cancer Informant and myself are also available for personalized consultations. If you would like a consultation about your case or that of a loved one, please contact us. No referrals necessary. Please join us for future episodes of the Cancer Informant. Have a wonderful day. Bye-bye.